Hello and welcome to this podcast. My name is Mohammad Farid Jabir, and in this podcast we'll be primarily discussing about opioid analgesics. We'll have a quick run through the WHO pain ladder and run through the different steps in the pain ladder and discuss later onwards about weak opioids and strong opioids. To start off, the WHO pain ladder was primarily applied to the management of cancer pain, but it's currently utilized as a guideline for the use of drugs for all kinds of pain. The general idea is to work up the ladder if the pain still persists. Analgesia ranges from simple over-the-counter medication to controlled drugs such as opioids. Guidelines suggest commencing oral drugs if the patient is in mild pain with non-opioid drugs such as paracetamol, and this can be further enhanced by the use of NSAIDs. If pain relief is not achieved or disease progression occurs, as in the case of cancers, the middle rung of the ladder is used, involve the addition of a weak opioid such as codeine. If pain still persists, the mild opioid is replaced by a strong opioid such as morphine, fentanyl, or oxycodone. From here onwards, pain control is by managing going up or down based on pain control. Commonly, escalating the opioid dose is needed until the patient is pain-free and there is minimal side effects from the analgesia. It is worth noting here that NSAIDs can be used at all three steps of the analgesic ladder, but most physicians are quite cautious with them as they have quite a few contraindications and side effects. Commonly, their ability to cause peptic ulcers, renal failure, deranged clotting, and its contraindication with elderly and asthmatics. Going on to the physiology of pain, damage to tissues cause the release of chemicals, primarily bradykinin, prostaglandins, and ETPA, and these stimulate pain receptors that initiate firing at the dorsal horn of the spinal cord. Neuropathic pain is described as shooting or burning sensation, which is caused by damage to neurons in the pain pathway and hence do not respond to opioids. Opioid peptides are endogenous chemicals produced by the brainstem in response to pain. These opioid peptides have analgesic properties and act upon the dorsal horns of neurons, which carry the sensation of pain. Opioid analgesics are drugs that tend to mimic these endogenous opioid peptides and cause prolonged analgesic effects by binding on to these opioid receptors. Opioid receptors are widely distributed throughout the CNS, and there are primarily three types: mu, kappa, and delta, of which mu is the commonest and primarily concentrated in the brain. This image here demonstrates the mechanism of action of opioid analgesics. What opioids do is primarily bind on to these mu opioid receptors at the end of the synapse, hence activating G protein. G protein is intracellular secondary messenger system that fundamentally brings about physiological changes. The physiological change brought about by the by the binding of opioids to mu opioid receptors is the opening up of potassium ion channels and the closing of calcium ion channels within the synapse. This closing of the calcium ion channels prevents the release of the neurotransmitter across the synapse, hence preventing the neurotransmission of pain. Going on to opioids themselves, starting off with weak opioids, which are used in mild to moderate pain. They may cause dependence and have been subject to abuse, but are less attractive to addicts due to the less of the buzz effect given by the stronger opioids. They are well absorbed orally, and 10% of the drug tends to be converted to morphine in the liver, which brings about the analgesic effect. Due to its side effects, that is constipation, nausea and vomiting, it has its limitations on its dosage, which produces less of the analgesic property which we desire. So the sensible thing would be to go one step up in the pain ladder and to use a strong opioid. Codeine also has antitussive and antidiarrheal properties. One specific area where it's commonly used is to help with chemotherapy-induced diarrhea, where the diarrhea can persist on for weeks. Going on to stronger opioid analgesics, which are primarily used in the treatment of dull or poorly localized pain. Parenteral morphine is widely used to treat severe pain, whereas oral morphine is the drug of choice in terminal care. We'll be discussing about the common strong opioid analgesics available and the different properties each one possesses. Starting off with morphine, which produces the following effects of analgesia: euphoria, sedation, respiratory depression, meiosis. The meiosis primarily occurs due to third nerve stimulation, nausea and vomiting due to stimulation of the chemoreceptor trigger zone in the brain, constipation primarily due to the effect of the drug on the nervous plexus in the gut, which inhibit gastric motility. Diamorphine, aka heroin or diacetylmorphine, is more lipid soluble than morphine, hence transfer across the cell membrane is more rapid, and due to this rapid onset of action, its sedative effects are brought about more quicker. Fentanyl is also a highly lipid soluble drug, which is commonly given IV to provide analgesia during maintenance anesthesia, and it could also be given transdermally in patients with chronic pain. Patches start off with 25 micrograms per hour and are changed every 3 days in response to pain control. Methadone is primarily used orally for maintenance treatment of heroin or morphine addicts in cases where it prevents the buzz from IV drugs. Buprenorphine patches are partial agonists at mu-opioid receptors. They have a very slow onset of action and has a much longer duration of action, roughly about 6 to 8 hours more than morphine. And this again is similarly as fentanyl is used in chronic pain. Going on to side effects of opioids, as mentioned earlier, the common side effects are nausea and vomiting. Ensure an antiemetic is prescribed. Constipation, a laxative should be prescribed. Respiratory depression, which is quite common in elderly folk. You would find that overnight nursing staff tend to bleep you to inform you that the respiratory rate of an elderly patient has decreased significantly and they are unrousable. Obviously, it's primarily because they are asleep, and secondly due to the opioid drug. Quick look at the drug cardex and see what drugs were given in the evening. Also have a good look at the as required section as well. And you would also notice on examination the patient would have pinpoint pupils. Inform nursing staff to monitor respiratory rate, and if you think that it's on the decrease, reversal of opioids would be necessary by using naloxone. Naloxone is a specific antagonist which binds onto these opioid receptors and reverses the action of opioids. Tolerance and dependence occurs when there is continuous treatment with opioid analgesics, and this is when abuse of opioid drugs occurs. In terminally ill patients or patients suffering from pain originating from a cancer, a steady increase in opioids is required. These situations can be quite tricky, as in the clinical context, dependence is unimportant. And due to junior doctors being overcautious with opioids, poor pain control tends to occur with these patients. It's best in these circumstances to seek senior help or even contact the pain team or palliative care team, who will be more than willing to help. That's about it for this podcast. Thank you and goodbye.